Hello everyone and welcome to our module on urinary tract malignancy. Let's start by talking about renal cell carcinoma, which is the most common form of kidney tumor. Renal cell carcinoma is usually derived from proximal tubular epithelial cells, so epithelial cells in this region of the nephron. And most renal cell carcinomas are composed of clear cells, like what's shown in this picture here. These are cells that are filled with lipids and glycogen, and for this reason, most renal cell carcinomas can also be called clear cell carcinomas. Renal cell carcinomas are more common in males, usually older males in the age range of 50 to 70 years. And renal cell carcinomas are more common in men who smoke. So here's a picture of an older man smoking a cigarette here on the screen to remind you of the classic demographic for renal cell carcinoma. Obesity is also a risk factor, and so is polycystic kidney disease. I talk about cystic kidney disease in another video, but patients born with that inherited disorder are at increased risk for renal cell carcinoma. Certain occupational exposures increase the risk of this cancer. In particular, asbestos does. We usually think of asbestos exposure as being a risk factor for lung cancer and pleural tumors like mesotheliomas, but a link is also well established between asbestos and renal cell carcinoma. And then finally, there's a rare inherited condition called von Hippel-Lindau disease, which we'll talk about later, and patients with that condition are at high risk for renal cell carcinoma. The classic triad of symptoms at presentation for renal cell carcinoma is hematuria, a palpable abdominal mass, and flank pain. Now, even though this is the classic triad, in reality only about 10% of patients or so present with all three elements of this triad. Most patients present with fever, weight loss, and hematuria. And unfortunately, many patients are asymptomatic until the disease is advanced, and so at the time of presentation, about a quarter or so already have metastases and advanced disease, which makes renal cell carcinoma difficult to treat. Renal cell carcinomas frequently invade the renal vein, and when they do this, they can cause thrombosis, which can block drainage of the renal veins or the IVC. This can also block drainage of the testicles, and when that happens, it can cause a varicocele. If you look at this drawing on the screen here, the left renal vein has a long course because it crosses the aorta to get into the inferior vena cava, and the left testicular vein drains into the left renal vein. So because of this long course for venous drainage of the left testicle, left-sided varicoceles are very common and are rarely related to malignancy. On the other hand, the right testicular vein drains directly into the IVC, so right-sided varicoceles in males are extremely uncommon. And so when a male presents with an isolated right-sided varicoceles, one of the things that must be considered is that there could be a thrombosis of the inferior vena cava, and that could be from a renal cell carcinoma. Because renal cell carcinomas commonly invade the renal veins, they spread through the venous system. Often they go directly to the lungs, but they can also travel to the bone. And in addition to metastasizing to lung and bones, the tumors can also spread to retroperitoneal lymph nodes. There are some paraneoplastic syndromes associated with renal cell carcinoma. The first one is polycythemia, which means a high hematocrit. That's because these tumors often produce erythropoietin, which is normally produced by the kidney. It's produced in excess by renal cell carcinomas, and that can lead to polycythemia. Hypercalcemia is also associated with renal cell carcinomas. These tumors sometimes produce parathyroid hormone-related peptide, which is a protein that has similar effects to parathyroid hormone, and this will increase the calcium uptake from bones and can cause hypercalcemia. The diagnosis is always by abdominal CT scan, and once a mass is identified, a biopsy is performed. If you look at this CAT scan on the screen, the left kidney is normal, the right kidney has this mass attached to it, and that's evidence of a cancer, and in this case it turned out to be renal cell carcinoma. The treatment of renal cell carcinoma begins with nephrectomy, either a partial nephrectomy or a radical nephrectomy, meaning removal of the entire kidney as well as some of the surrounding tissue. Unfortunately, renal cell carcinoma is poorly responsive to chemotherapy and radiation, so these modalities usually are not used. Back when I was in training, the mainstay of treating renal cell carcinoma was with immunotherapy using a drug called aldesleukin, which was interleukin-2. So the thing you want to remember about renal cell carcinoma, and this may come up in your boards, is that T cells are great at destroying renal cell carcinoma if you can find a way to activate them. So the older way to activate them that's used less commonly these days is to administer interleukin-2. You may have forgotten this from immunology, but IL-2 is a very potent stimulator of T cells, so it would activate T cells to destroy the renal cell carcinoma. Unfortunately, there are a lot of side effects to aldesleukin, things like hypotension, fever, and chills, and many patients were unable to tolerate these drugs. Nowadays, IL-2 is used much less frequently because we have other drugs that trigger T cell growth called checkpoint inhibitors. What these drugs do is block checkpoint proteins so that the T cells will begin to grow. You may recall from cell biology that there is a cell cycle where T cells move through various stages like G1, S, G2, and then M, and then they ultimately divide and replicate. There are T cell proteins called checkpoint proteins that block progression through this cell cycle and therefore block the growth of T cells. What checkpoint inhibitors do is they knock out those checkpoint proteins and therefore the T cells will grow and divide. There are two checkpoint pathways that are targeted by these drugs. One is called the PD-1 pathway, the other is called the CTLA-4 pathway. A drug called nivolumab is used to target the PD-1 pathway, and another drug called ipilimumab is used to target the CTLA-4 pathway. But whichever drug you use, the idea is the same. You're targeting those checkpoint proteins so that T cells will grow and attack the renal cell carcinoma. This is the same thing that IL-2 did, but because the mechanism is different, the side effects of checkpoint inhibitors are relatively mild compared to aldesleukin and IL-2. Let's talk briefly about the genetics of renal cell carcinoma. Renal cell carcinomas are associated with a gene deletion on chromosome 3 of the von Hippel-Lindau gene, or the VHL gene. Patients who develop sporadic mutations often have single tumors, and this is your typical older patient who's usually a smoker. That patient probably has developed a sporadic mutation of the VHL gene. Some patients inherit a VHL gene mutation. Those patients tend to get renal cell carcinoma at a younger age, and they also tend to have multiple bilateral tumors. So that's a nice segue into von Hippel-Lindau disease, which is a very rare autosomal dominant genetic disorder caused by VHL gene inactivation. Patients with this disorder have many tumors, including renal cell carcinomas, but also cerebellar hemangioblastomas, retinal hemangioblastomas, and others. The diagnosis is made through genetic testing, and what you want to remember about this disorder for your boards is that these patients need frequent screening for early development of tumors. So they need an annual eye exam to detect retinal tumors, and they need annual MRIs of the abdomen, spine, and brain to detect things like renal cell carcinomas and cerebellar hemangioblastomas. Moving on, let's talk about bladder cancer. The most common form of bladder cancer is called transitional cell carcinoma. These forms of bladder cancer derive from the endothelial layer of the bladder, which is called the urothelium. And so for that reason, transitional cell carcinomas are also called urothelial carcinomas. This is the most common overall tumor of the urinary tract. Bladder cancer is more common than renal cancer. And usually transitional cell carcinomas arise in the bladder, but you should know that they can also sometimes arise in the renal calyces, the renal pelvis, or in the ureters, because all of these things contain a urothelium just like the bladder. Risk factors for transitional cell carcinoma are shown on this slide. First of all, smoking is a major risk factor for bladder cancer. Cyclophosphamide is a chemotherapy agent, and you may know that one of the side effects of cyclophosphamide is hemorrhagic cystitis, and that's because cyclophosphamide has a metabolite that is damaging to the bladder, and in addition to causing cystitis, that can also lead over time to transitional cell carcinoma. Phenacetin is a drug that was taken off the market. It's similar to acetaminophen, but years ago when people used to take this as a pain reliever, it could lead to transitional cell carcinoma. Aniline dyes are sometimes used in hair coloring, and so for this reason, people who are hairdressers are sometimes exposed to aniline dyes, and that can put them at risk for this form of bladder cancer. And then finally, there are a couple of workplace exposures that have been linked to transitional cell carcinoma. Most of these involve things that people are exposed to when they work in the rubber, textile, or leather industries. Naphthalene is an industrial solvent that is commonly used in these industries, and it's been linked to transitional cell carcinoma. So the types of patients who could be at increased risk are patients who are painters, machinists, or printers. All of them are exposed to naphthalene. The classic presentation of transitional cell carcinoma is painless hematuria. So the classic case is going to be an older white male because this tumor is more common in men who are older. The patient will probably be a smoker because smoking is a very important risk factor. The patient will complain of painless hematuria and have a urine that looks like this. And importantly, when you look at the urine under the microscope, there will be no dysmorphic red cells or red blood cell casts. Dysmorphic red cells and red blood cell casts indicate glomerular nephritis, and in transitional cell carcinoma, none of those things are going to be present. The test of choice for diagnosis is cystoscopy and biopsy. Cystoscopy is done as shown on the screen here. A cystoscope, which is a camera, is inserted into the bladder, and you can visualize the bladder tumor and take a sample for biopsy. The management of bladder cancer depends on whether or not the tumor has invaded the smooth muscle of the bladder. If there's no smooth muscle invasion, then a procedure called a TURBT can be done. This is a transurethral resection of the bladder tumor, and basically it's a resection that's done through the cystoscope to remove the tumor from the bladder wall. If there is invasion of the bladder smooth muscle, then there are a couple of options. First of all, cystectomy, which is removal of the bladder, can be done. After this, patients will have a conduit for urine into a bag attached to the abdomen to drain urine. Chemotherapy can be used. And then finally, there's a special treatment used for bladder cancer called intravesical BCG. BCG is Bacillus calmette-guerin. It's a live attenuated strain of a form of mycobacteria called Mycobacteria bovis, and attenuated means it's been weakened. And it's injected into the bladder, that's why it's called intravesical therapy, and it triggers an immune response that has been shown to be effective in patients with bladder cancer. Okay, so as I said before, the majority of bladder cancers are transitional cell carcinomas, also known as urothelial carcinomas. But there are some less common forms of bladder cancer, and let's talk about those now. The first one is squamous cell carcinoma of the bladder. This is a rare bladder cancer that is associated with chronic inflammation of the bladder. So this form of bladder cancer tends to occur with special risk factors. The first one is patients who have had recurrent kidney stones or cystitis. These patients often have chronic inflammation of the bladder, and that can lead to squamous cell carcinoma. The second group are patients who have urinary tract infections with the Helminth schistosoma hematobium, and this is high yield to know for your boards. This infection often leads to squamous cell carcinoma of the bladder. Schistosoma is a trematode. It's found in Africa and the Middle East. In particular, there are high rates of chronic infection in Sudan and Egypt. So patients in these areas often have chronic infection with schistosoma, and therefore there are lots of squamous cell carcinomas of the bladder found in these countries. The infection is acquired from fresh water that contain larvae which penetrate the skin, and then they migrate to the liver where they mature as adults. The adult worms infect the bladder and lay eggs which cause granulomatous inflammation, which is a form of chronic inflammation. This usually causes hematuria, so many patients with this infection have chronic hematuria, and then over time, if the infection is not treated, these patients can develop bladder cancer. The final form of bladder cancer we'll discuss is adenocarcinoma. This is a very rare bladder cancer caused by glandular proliferation in the bladder, and normally there's no glandular tissue found in the bladder. So for that reason, adenocarcinoma only occurs in a couple of special circumstances. The first one is if there's a remnant of the embryonic structure of the urachus left behind in the bladder. We'll talk about that in a minute. The second one is infection with schistosoma. Most patients with infection with schistosoma develop squamous cell carcinoma, but a minority will develop adenocarcinoma. And then lastly, children born with exstrophy of the bladder are at increased risk of adenocarcinoma of the bladder. Exstrophy is when the bladder protrudes through an abdominal wall defect. This is repaired, but years later these children can sometimes go on to develop adenocarcinoma. The urachus is an embryonic structure that connects the dome of the bladder to the umbilicus, and normally it's completely obliterated at birth and becomes the medial umbilical ligament. However, if there is failed or incomplete obliteration, a couple of problems can develop. First of all, sometimes babies are born with urine leaking from the umbilicus, and that's because the urachus has not obliterated. Incomplete obliteration can also lead to the formation of cysts or sinuses or diverticulum, and these can sometimes become infected. But then finally, if a piece of the urachus is left attached to the bladder, it can go on to turn into adenocarcinoma. So a urachal remnant is a common mechanism by which patients develop the rare bladder cancer, adenocarcinoma. And that concludes our video on urinary malignancy.